Welcome. In this clinical briefing, we're going to break down the critical guidelines for managing infections in cancer patients and turn them into actionable pearls you can use in your pharmacy practice today. Here's what we've got on tap. We'll start with why this is such a big deal, then move into how to spot at-risk patients. We'll look at our treatment options, dive deep into the crucial counseling points, and wrap up with prevention. Let's get right into it.
So first things first, let's set the stage. Why is this topic so incredibly critical for the patients we see every single day?
Well, here's the tough reality of it. The very treatments that are helping our patients survive cancer are also the ones that can really weaken their immune systems. It's this difficult balancing act that makes infections a major threat. And this is exactly where our expertise as pharmacists becomes absolutely vital.
Okay, if there's one concept we absolutely have to have locked down, it's neutropenia. This isn't just some lab value on a screen, it's pretty much the central pillar of how we assess risk. It's not just if they're neutropenic, but how low they go, especially that profound level, and for how long. Those are the two factors that really open the door to serious life-threatening infections.
All right, let's get practical. When you're looking at a patient's profile, how do you actually identify who's at the highest risk? What should you be looking for?
Think of this as your quick mental checklist. First, where are they in their chemo cycle? And what type of cancer is it? We've already talked about neutropenia, of course, but are there any specific signs? Things like pain or feeling short of breath. And finally, don't forget the risks we introduce, things like central lines, which can be a direct highway for bacteria.
Burn this number into your memory. 7 days. If a patient's neutropenia is expected to last longer than a week, that's the magic number. It's a critical threshold that officially bumps them into that high-risk category and means we need to be much more aggressive in how we manage them.
So now that we have a good handle on how to spot the risk, let's talk about our tools. What's in our antimicrobial arsenal, and how do we pick the right weapon for the job?
You can really break patients down into two main buckets. In one bucket, you have your low-risk patient. Their cancer is under control, they're pretty stable otherwise, and they might be a great candidate for oral antibiotics they can take at home. But in the other bucket, you have your high-risk patient. They've got other health issues, their cancer's not well controlled, and for them, it's straight to the hospital for immediate IV therapy. That distinction is everything. And for those high-risk folks, these are our heavy hitters. These are the workhorses. The guidelines are clear. You start them, and you start them fast, on one of these broad-spectrum beta-lactams that covers Pseudomonas. This gives us the strong coverage we need right out of the gate while we're waiting on cultures. And here is a perfect example of smart antibiotic stewardship in action. We don't just throw vancomycin at everybody, no way. You save it for patients who have these very specific risk factors for resistant gram-positive bugs. And if the cultures come back and don't show anything, you stop it. It's all about targeted therapy. Okay, this section is huge because it really gets to the heart of what we do best, providing clear, effective counseling on some pretty powerful and, let's be honest, complex medications.
Let's start with a class we see all the time, right? The fluoroquinolones. They're a cornerstone for both treatment and prevention, but they come with some key counseling points that we absolutely cannot afford to miss.
So let's talk real-world counseling. Yeah, we need to mention the QTC risk and the potential for dizziness, but you know what you're probably going to catch most often? That cation binding issue. Just reminding a patient to take their Cipro at least 2 hours apart from their multivitamin, their calcium, or their Tums, that is a critical intervention that ensures the drug actually gets absorbed and works.
All right, next up, our go-to for gram-positives, vancomycin. This is a powerhouse drug, and it really demands careful attention from the entire healthcare team to use it safely.
The big thing to get here is the direct link between how we give the drug and the side effects it causes. That red man syndrome or flushing, that's all about the infusion rate. We have to make sure it's given nice and slow. And for nephrotoxicity, it's all about being vigilant, keeping a close eye on kidney function, especially if they're also on other tough-on-the-kidneys drugs, like the cisplatin that so many of our oncology patients get.
Let's move on to our really important antifungal, voriconazole, which we use for nasty stuff like invasive aspergillosis. It's effective, but it has some really unique side effects and, this is the big one, a ton of drug interactions we have to manage.
The visual stuff is super common and can be pretty scary for a patient. So just reassuring them that seeing things a bit blurry or noticing color changes is expected and that it usually goes away is a really important bit of counseling. But honestly, from a safety standpoint, our number one job is that drug interaction check. Voriconazole messes with the CYP enzymes in a big way,
affecting everything from statins to warfarin. We have to be on high alert with this one.
All right, let's switch gears a bit. We've talked a lot about treatment, but what about getting ahead of the curve? How can we actually prevent an infection from taking hold in our most vulnerable patients?
Now, prophylaxis is not for everybody. It's a very targeted, evidence-based strategy. We save it for these specific, high-risk groups where we know the benefit of preventing an infection is absolutely going to outweigh the risks of things like antibiotic resistance or side effects.
And look, the evidence here is just undeniable. For those high-risk hematology patients, using a fluoroquinolone for prevention isn't just about stopping a fever. The data is crystal clear. It actually reduces mortality. It saves lives. That's an incredibly powerful outcome that we can directly influence. And when it comes to fungi, we also have to be very specific. It's like using the right key for the right lock. Fluconazole is great for Candida, sure, but it does nothing for molds like Aspergillus. So, in those really high-risk patients, think bone marrow transplant, where aspergillosis is a huge concern. Posaconazole is definitely the superior choice for prevention.
So let's just boil this all down. What do you need to take back to your practice? First, always assess risk based on how deep and how long the neutropenia is. Second, for high-risk patients with a fever, act fast with those big gun IV antibiotics. Third, really own the counseling on these key drugs: Vanc, fluoroquinolones, voriconazole. And finally, use prophylaxis, but use it wisely, only in the patients who are proven to benefit.
We've gone through the whole playbook here. The challenge now is to put these pearls into practice. Whether it's catching that one chelation interaction on a prescription tomorrow or flagging a patient profile for prophylaxis, it's those small, smart actions that make a huge difference in keeping our patients safe. Thanks for tuning in.